So described that there was a nasal cyst here on this exam. So can somebody, anybody want to take a stab at what we're looking at?
Is the globe ruptured and then either vitreous or silicone prolapsed under that conjunctiva?
It's a good thought. Anybody else? So this is a case of trauma that came to see me as a second opinion from somewhere in the Middle East. And actually what happened here is that there was a scleral rupture. There was not a conjunctival rupture, although it's kind of bunched up there. There was no surgery done. But this is the crystalline lens that has made its way
So cool.
subconj, which is the coolest picture. Okay, so I and the patient was probably light perception at that time. Oh, thank you. And I decided, oh, there's breakfast behind this. And we decided to not do anything for this patient. Pretty poor visual potential. Anyway, so this is not advancing.
Oh, you point this way. Okay, let me see. Hold on, I got to click here. Try now. Okay, let me see.
Oh, there we go. Okay, so I left in a lot of the BCSC chapter 15 information, but I did take out the surgical steps. I did take out the surgical steps for closing ruptured globes and for intraocular foreign bodies, just because it doesn't fit in this amount of time. But I'm happy to give that lecture if you guys ever want to talk about, you know, my approach. I'm sure all your attendings have different approaches to closing ruptured globes. I'm really happy to give you that talk. Okay, so we have classifications of blunt trauma, no break in the eye wall, and then penetrating and perforating trauma. And you know, I think that it's important to know the difference. What do you think is the difference between penetrating and perforating?
Penetrating, it just goes in one aspect of the eye. Perforating
it through and through, right? So it does make a difference in your surgical planning. You know, if you're going to do a vitrectomy on this person, if there's a penetrating injury, that's one thing. But if it's a perforating injury and you don't know how to close, if you can't close the back of it, you know, that has to wait. So intraocular foreign body, both penetrating and perforating, are options. So this OTS score is widely quoted and would be important for if a patient actually asked you what are my chances of having X or Y vision. But in my experience, good morning, my experience, the patients don't typically ask that question. They're really overwhelmed in the beginning. Maybe the family members might have enough perspective to ask these questions, and you can calculate, you know, what the chances are of them getting, you know, 20/40 vision, depending on their presenting vision and all of this list. So it's nice to be able to consult, but I don't think I don't use it often. Just know that, you know, I mean, the obvious things, if you have poor vision to start with, a globe rupture and endophthalmitis, they don't do as well. So I'll definitely take a history. Sometimes this is possible. Sometimes patients are in the trauma bay and they're not really it's not really possible. Where I trained and worked with most of my ruptured globes, I did need to know the NPO status. I think in some of the community hospitals, it's not as important. The anesthesia will take people to the OR, even if they're not NPO. But you know, worthwhile to know. And always ask what the visual status was before trauma. You'll be surprised to know that how many people are amblyopic in an eye that they have trauma in. And sometimes I think it's that they're not protecting that eye, you know, they don't have good vision and don't see things coming to protect themselves. And also other surgeries are really important. Somebody who's had a PK and you can't really tell what's going on, you have to have a high threshold to think that this PK is dehisced, because it might bring other services into the mix. You know, you might say, okay, I want to ask the cornea people to be on standby if this PK has problems. And it might, in my actually, where I used to do most of the globes, a dehisced PK would go to cornea but every other ruptured globe would be done by the trauma service, the residents mostly. Strabismus is also important to know because sometimes you have to take these muscles down to close ruptures, and you want to know if they've already been taken down, because it's possible that they've been that a muscle or two has been taken down in the past, and you don't necessarily want to be taking other muscles down and compromise more blood supply to the globe. So sometimes strabismus is really hard to get a history from about, because the patients were young. So if you can't, if you're having trouble examining these patients, just stop and take them to the OR. There's no reason to, go further. You can consent the patient for exam under anesthesia and any other necessary procedures, including ruptured globe repair, et cetera. Always look for the APD. Don't trust the vision, especially in patients who are in the trauma bay. They're oftentimes intoxicated. They're oftentimes, they can be children. And so don't necessarily go by that, especially if you're deciding, oh, this patient's MLP, I'm not going to remove an intraocular foreign body. Well, they might actually have better vision than that, but definitely give them a while, recheck it later. And then if you don't think if there's not any evidence of a ruptured globe, you can take a pressure, because sometimes these patients have hypemas and you don't want to miss one thing and focus on another. Let's see. Always examine the other eye. So even if the patient comes in with what you think is a rupture in one eye, before you're going anywhere, definitely examine the other eye. The worst thing is to take somebody to surgery, come back, and have the other eye have a problem that you need to look at, that you can't, etc.
Reportable.
Pardon?
That's reportable.
Yes, definitely. So anterior exam. So really, I think it's important to be methodical about this. Sometimes you go in and you're so overwhelmed because there are all of these, there's the huge corneal laceration, uvea coming out, and you miss a marginal lid laceration because you're so, into that. And that might affect your surgical approach. I don't know if I used to just do the marginal lid lax myself, but it's possible that maybe oculoplastics needs to be there to do something else, or the patient needs to be referred out subsequently to fix this, and you should arrange that. So just go and, where you have an epic, at least that's how I used to have it, like lids, lashes, conjunctiva sclera. Actually, just think about every step in any stressful patient. Think about every exam bullet, and that will really help you. Let's see. So oftentimes you'll lose a crystalline lens or an IOL. Important to check on that. But yeah, just every part of the exam. So definitely don't dilate if iris is plugging a wound, or you think iris is plugging a wound, because you have a stable globe and you can have an unstable globe. That being said, I've seen many people dilated and usually it doesn't unplug. That usually the dilating drops are not enough to rip an iris out of a corneal wound that's plugging, but avoid that. Otherwise, you can dilate the patient, especially if you think there's going to be clear media. It's good to have a documented exam before. It's a little harder to do a dilated exam when you're scrubbed than it is at the slit lamp and everything. If anybody wants breakfast, go ahead. I can keep going. So if there is suspicion for a ruptured globe, definitely get CT of the orbits, thin cuts, and look at it yourself. So MRIs don't come first. A B scan is only appropriate if in things like, for instance, say a needle, a needle entry into a cornea, like something like an AC tap type of thing. You're not going to be B scanning patients with true ruptures. I want to, can we turn the volume down or off on this?
Oh yeah, sure.
So just because you're going to hear whatever was in the trauma bay there.
Good.
Okay.
I don't know if people can hear us though.
Well, okay, now I can't advance.
Taken over. All right, yeah, the sound's taken over by them. Hold on. There we go.
Okay, it's okay. I don't think we need to go through all of these, or I can click them. Although
Here's
here's,
one.
oh, okay. There it is. Okay, so let's just keep going. This is some of the exams are really confusing and you might not know what you're looking at. So ask for help. This is a patient who is amblyopic in her other eye who had a car accident. And I remember the residents coming to ask me what is going on. And you can't find a globe. She was auto-enucleated during, or traumatic enucleation. And so it's, sometimes they're very confusing. They have tons of facial trauma. And so, yeah, well, it was an example that she was trying to tell me there's no globe there, you know? All right, so this is a lot of BCSC information. So choroidal ruptures are tears in Bruch's membrane. RPE and fibrous tissue goes into the choroid capillaris, and they're usually concentric. They're usually in this shape, and oftentimes they go straight through the fovea for whatever reason. But this one is just a little off to the side. So watch these patients for choroidal neovascular membranes. Injections do work on these patients, especially somebody like this actually could do fairly well. Macular holes, I've seen them in younger people, older people, they oftentimes close. So we just counsel them that they're very often to close. And I usually don't operate on these until at least 6 weeks after an injury. But they actually do. I had a 15-year-old this year that had pretty poor presenting vision, and after his a macular hole repair, he was 20/40-ish. So they can do really well, even though their whole macula can look like have a lot of commotio Berlin's edema, and they can look pretty bad. Especially young people can have pretty good outcomes. Scleropateria, I rarely see, and these are large areas of choroidal and retinal rupture and necrosis, and there's oftentimes a lot of hemorrhage, and they can, have large scars in the periphery or the posterior pole.
That actually is sort of defined by no scleral rupture.
Right.
You see it more often than you want down here.
Yeah.
I remember it. You seen it?
Yeah.
I never heard of scleropateria in all my training until I came here.
Well, in a level 1 trauma center, that's the kind of thing you'll see, right? So
they tend not to detach, which is weird.
They're probably just so scarred down.
It's a strange little thing.
Well, and if there's no rupture, then the retina's, doesn't have as many breaks.
But the retina's missing there. It's disrupted, but that's right. You don't have to do anything. Just document it and keep on trying.
Can they get neovascularization or any other sequela if you're following them?
I haven't seen that happen with these patients.
That was scleropateria.
And usually it's not in the periphery. It's usually
there was a
bullet or a BB.
Yeah, they're high projectile, high speed projectiles.
With neovascularization, I think choroidal rupture, there was a goofy paper years ago, I remember, where the closer the choroidal rupture is to the fovea, the more likely it'll turn into neovascularization.
Just bad luck getting worse.
It's an interesting thing.
But maybe if it's straight through the fovea, it doesn't matter as much because their visual potential is not as good. But so scleral rupture happens oftentimes at the thinnest parts, which is at intersections of tissues, limbus, muscle insertions. Old phaco wounds are like the most commonplace, which makes sense. So if you have an old extracap wound or an old corneal wound, I mean, the iris can just come out of there. Those are some of the easiest cases to reposit the iris. And I already told you about PKs, so think about that. Let's see.
You're going to be on that screen. Click there.
Click which one?
Yeah, click on that.
Oh, there we go.
Okay.
So perforating injuries, we already discussed, have entry and exit wounds. And basically there's scar tissue or fibrous proliferation between the two sometimes through the vitreous scaffold. And these usually will seal within a week. So that is why a lot of these patients with posterior ruptures, you'll wait a week to go in and fix a detachment or things like, or remove a vitreous hemorrhage and see what's back there. And small posterior, well, actually a lot of posterior wounds can be left and they can close by themselves. You can't even get to them. And if you're going to get to them, you're going to extrude so much vitreous and intraocular contents that it's not worth, going in to close them. So you have to think about how far anterior it comes. And we talked about what to do for vitrectomies. So penetrating injuries, I'm not going to go through actually the surgical steps. We don't have quite enough time, but I just put in my ruptured globe protocol. NPO and bed rest is important. Usually these patients don't want to get up, but once in a while they do. So a Fox shield is important. You don't want them to be manipulating their own globe to see what's going on there. And always review these videos of the CTs by yourself, because the radiology reads are oftentimes not correct. They cannot see with the detail that you can see. So look for irregular globe contour, air, intraocular foreign body, hyperlucency. And if you're going to staff this with your attending, bring a video, if you can't easily pull this up wherever you are. I use fortified vancomycin and tobramycin every hour until they go to the OR. And I use PO Levaquin ×1. I know some people some patients are admitted for ruptured globes and they stay in the hospital for days. I discharge them same day, but they get Levaquin ×1, and I also inject intravitreal antibiotics or intracameral, depending on the clinical situation. If I can't tell what's back there, sometimes I would skip that and not put a needle where I can't see. But in the setting of intravitreal or intracameral antibiotics, lots and lots of globes, I have not had an endophthalmitis happen. I mean, knock on wood, I'm sure it will happen one day, but so with this protocol, it works really well.
What do you inject into the eye?
Vancomycin and ceftazidime. And if it was a vegetable matter, then I might use an antifungal as well.
Would you use borate?
Yes. And I make sure to order those. I don't know about at TGH how easy they are, but as soon as I get a ruptured globe, I order the antibiotics, and I usually physically have them with me because they're always lost.
We keep the pharmacy busy with those. So.
Right, I'm sure you do. So don't let them go home. Okay. I've seen, I don't know how the admission process works here, but at Bascom Palmer, once in a blue moon, somebody would have gone home and been coming back the next day for the ruptured globe. That's a huge miss. You can never let them go home. And I think that was just, mistakes that happen. And make sure that they are going to be healthy enough and stable enough to be done at whatever facility. You all are going out into the world, and it's possible that the hospital that you take trauma call at is just not equipped for whatever you're planning. And just make sure that, a TGH, of course, is going to be equipped for everything, but just make sure that they are medically stable enough. These patients often have a lot of other injuries. So I think that's just another ruptured globe. So this is important. I always try, even with detachments and ruptured globes, to have a family member or a good friend present at this discussion. The patients won't remember most of what you say, I think, but the family members oftentimes will. And then family members can remind the patients, oh, you remember we talked about this, So the goals of surgery, I always tell patients, are to attempt to close the globe, and don't promise that you can. Sometimes you cannot. And to prevent infection. Basically, keep your eyeball in your head, and then you'll have to figure out months later. Pardon?
Can I tell a story?
Oh yeah, please.
So this guy named Borikov was Goldman's partner up in Boston, and he taught me as a medical student. And he would do most of the PKPs, and Dolman and he controlled the eye bank. I mean, they were ruthless enough. He was great. Yeah, he just had a great Jewish sense of humor. So said, you know, when you talk to the patient, ruptured globe, you say, you go out and say, Billy, we got a serious problem, but I'm gonna do everything I can to save the eye. And then the family will go, well, what about vision? And he said, your response is, who's talking vision?
Yeah. It's definitely helpful. Okay, so I just tell them we'll have to wait several months to know if there will be vision. And that
100 years old.
I think the other things maybe we'll skip through because I don't want to take too long. But usually these are done in under general anesthesia. I used to do them, tons of them under MAC block, which can be done, but it usually requires a skilled retrobulbar blocker, you know, whoever that is. And it can be dangerous if you don't have somebody who's super skilled at that. So if this is your 50th retrobulbar block, do not be doing it on a ruptured globe. You know, this was done with anesthesiologists who only did eyes. And so it's maybe better to just do it under general.
I lost one patient under general because they weren't in PO, but I would not. If you put a needle in the eye and you get a hemorrhage,
yeah,
it's going to be on you.
Yeah, there are papers to suggest that it's reasonable with selected patients, but if at all possible, just go ahead and put them under general. The time.
Ingrid Scott, I saw her name.
Yeah. The timing is definitely ASAP. I do them within 24 hours, but it doesn't need to be within 2 hours, you know, necessarily. Some of these patients do really well, but as soon as you can get it done. I always tell people it's better to get a good team together and do it within 24 hours than it is to do it within 1 hour with, you know, incorrect, not the best team or not the best equipment or, you know, always think about neurosurgical problems if they're in the ICU, things like that. And know if they have like a big femur fracture, they should be under general, you know, like people who can't lay flat, etc. for sure. Oh, this is a cool video. I figured I would show this to you. So this is a guy who is an electrician and got a wrench, a big wrench. Wow. And so we had to do this with neurosurgery. So neurosurgery had him was working. I can't remember how you describe it, where like they removed the calvarium, but they were working on that while we were working down here to close his globe. It actually closed really well. He didn't have vision in this eye, but the wrench went so fast that it just made a single incision.
It's actually how they used to do lobotomies. They go in through the orbit.
Yeah, this
with like a needle.
Yeah.
And they scramble for frontal lobotomies before they had antipsychotic.
This is how his face looked afterwards. It looked great. Yeah, it looked great. He didn't he has NLP, but so remember for your OCAPs and boards, the open globe classifications. The cornea or limbus is zone 1, then 5 millimeters anterior of the anterior sclera is 2, and then full thickness posterior to 5 millimeters from the limbus is 3. So oftentimes, and we know this from the military, that sometimes they had delayed closure and removal of intraocular foreign bodies. So we know that inert sterile foreign bodies can be well tolerated. We don't suggest that we leave them in there, but if they can't be removed for whatever reason, they can be well tolerated. Zinc and aluminum are okay for the most part, but copper and iron cause a lot of problems. And so copper is called calcosis, and it can cause an endophthalmitis-like inflammatory reaction. You can see this is definitely a testable bullet point. Deposits in decimase, aqueous particles, green iris, sunflower cataract, vitreous opacities, metallic flecks on the retinal vessels, and ILM. I have never seen a case of calcosis.
Never seen it, heard it.
Yeah.
It's a shame what they test down.
It is, but they can.
And this is some of the more benign
Yeah.
stuff. They'll be like, oh, sunflower powder, what kind of metal was it? Thank you, God, for this question.
Right. But you'll never actually see it. So, iris siderosis, iris sphincter and dilator deposition, retinal photoreceptor and RPE cells are susceptible, and you can, and the test will say that you have to get an ERG. So we already discussed that you should get a CT orbits with thin cuts to detect an intraocular foreign body if there's a media opacity, and probably even if there's not a media opacity, just because they can be hiding in other places and you want to know where they are. This is a case where I was one of my third-year resident told me that they couldn't find, they did not know where the foreign body was, but we need to take them to the OR to explore and find it. And it was an odd story to me because usually they would tell me where it was. So I just went down to see the patient, which usually we didn't necessarily do. They would just take them to the OR. And then there's this I said, we should be able to find that. We should be able to see that. So I just flipped the lid and the BB came right out. And I put it in his palm where he looked like totally dazed. And I said, let this be a lesson, flip the lid.
We get these a lot with like orbital fractures and stuff. Sometimes patients will be like, oh, another orbital fracture will clear the globe. But if you don't review the films yourself, you'll often find there's like pieces of glass in the fornix, pieces of glass in the conch.
Right.
And if you don't take those out, ENT's not going to tell you they're there. You might miss them.
Right. Yeah. And the ER doctors will not necessarily take them out either.
I almost missed one night. I was just tired. I was like, oh, stupid.
Yeah, then you come back at week 1 and it's really hard to get them out, right? So intraorbital oftentimes doesn't need to come out, but I always used to staff these with oculoplastics. I'm not sure if you have oculoplastics to staff those with. But
we have the finest oculoplastics ever, Dr. Sloan.
Oh, okay. So he will will help with that.
He's like always on call, and he's still going.
He's done it all his life.
Yeah.
It's amazing, and he's always pleasant.
I actually take call at for a bunch of the Baycare hospitals, and they always say that there's no oculoplastics at TGH. Now I'll know that.
Don't tell them there is.
He's taking the call, so anyway.
He comes in.
He comes in to be nice.
Some residents.
So there may be multiple intraocular foreign bodies, so always remember the method of injury, gunshot wound or something like that. Let's see. So when do you not operate? So in an NLPI, you could consider just closing the globe and not removing the intraocular foreign body. Sometimes it's a mess and you're not going to be able to remove it well because there's too much blood and bleeding. So and tell the patients they can't have MRIs in the future because you don't know what type of metal it necessarily is. You can never trust what type of metal they might tell you it is. And those patients oftentimes end up with enucleation. See. Okay, so common stuff kind of, let me see if I missed something. Okay, down the road. Yeah.
Really quick, this isn't really like an open globe situation. If someone has a trauma and their pseudophakic lens is resting on the retina, how much time or when should you take that out?
Oh, that can stay there for years if it needs to. That is not an emergency at all. Only really if there are other injuries. And sometimes if there's vitreous coming forward and their pressure goes up or it's decompensated in their cornea, but for the most part, that's a very routine surgery, a routine referral. And if the patient doesn't have insurance, it doesn't go emergently, they can. I've seen patients who just get a contact lens and they live with that, that lens in their eye forever.
Yeah, they can. Some of the 3 pieces, they can tear a retina. Oh,
yeah, probably.
Just from one of my
from bouncing,
Yeah, one of my friends put one in the vitreous and they put one in the AC. And after a while, he sent the patient me, and the bottom of the retina was a mess.
Very interesting. Do you see that?
I'm not, I think that could be the surgery though. I think the long-standing lenses, I think they can bounce around. But in any traumatic surgery.
The
traumatic.
surgery itself
Yeah,
might
traumatic
be,
surgery.
and the
I actually just had a
method of
patient recently. I had a dislocated lens patient. It was a surgery, they put the lens in, everything was kind of messed up.
right.
I told him, let's wait a month, he had CME, quiet the eye, he comes back with a total RD.
Well,
And
yeah,
I was
that-
like, did your vision get, he's like, yeah, about a week or two ago, it seems like I lost my vision.
Well, you're basically, you're disturbing the vitreous at that point, so that can cause tears and hemorrhage and all that stuff, so. But I think that, atraumatic lens dislocations, like in a 80-year-old patient, that their lens drops, I haven't seen
Yes, no.
I haven't seen that cause huge problems. So definitely gonio these patients, even if they have mild trauma, gonio them at 6 weeks, because the angle recession can be seen, and those people need to know that they need to be followed for this. So, your high FEMA patient needs to be followed probably yearly forever, because they will have an increased risk of glaucoma for their
If the
lifetime.
gonio is okay, do they not need to worry about it?
I think that they still should have
Okay.
yearly eye exams, but I think I worry less. I'll see them. I'll refer them really to a general ophthalmologist a lot more readily if they have angle recession.
Yeah, I saw a patient once who had an injury, did fine, and then they said, 20 years later, I went to the doctor and I just went blind in the eye.
Yeah.
And they'd not been getting regular checks, and they must have had angle recession. Yeah, so I was like, you gotta go.
Right. Yeah. So post-traumatic endophthalmitis is about 2 to 7% of penetrating injuries. B serious is about 25% of post-traumatic endophthalmitis.
It's wire injuries.
Yeah.
It's unbelievable how common it is with wire.
I'm telling you, if you inject these patients with intravitreal antibiotics, it's incredible that I've just never
Yeah, that's
seen
nice. I've seen them both. By the hour, the eye, you can watch it.
Yeah, sometimes the patients
infection, you can't get rid of it.
with wires, sometimes they'll come in for the endophthalmitis, not for the ruptured globe, because they're so small. They thought they were like, oh, something got in my eye, now it's gone,
Yeah, but wire injury, it's very high on the list. And it's a spore former. And I don't know that you can get rid of it.
Yeah.
Maybe in the literature, but
yeah, it's one of those that probably you end up with a nucleation, or at least an eye full of oil. Sympathetic ophthalmia, if you can't close the globe or there no light perception, most of the time patients are offered enucleation, maybe not immediately. Usually I try to just close the globe and talk to them a few days later about it. And so you can offer it to them, and some will take you up on that, because especially if they're going to be able to have a prosthetic, if they have insurance and resources and they can get a prosthetic, it might be something that they're interested in. But it's not a very high risk, 1 in 500 for penetrating injuries. And primary evisceration is really, I think it's really traumatic to the patients emotionally more than anything. So I almost never have offered it unless it's just impossible. I know that it's going to be impossible to close the globe. And then the book will say to do the enucleation within 14 days.
I looked at this literature, it's a mess. It's old literature.
Yeah.
It's
they're not.
This is old teaching.
But it
Feels like a boogeyman.
Yeah, it still will be in your.
It's from the 1930s and 40s literature. I mean,
It will still be. It's still the most current, though. Really, it's still what's in the BCSC. So, if you have to answer the question, that's how you would answer it. Okay. Avulsion of the optic disc is very interesting. Basically, if you can see it with extreme rotation and forward displacement of the globes, and then it's hard to find a picture of it because usually there's blood covering it, right? But it just looks like a sunken nerve, really sunken nerve.